Hello, I'm Dr. Caminiti. Nice to see you again. And continuing in our lecture series for oral surgery regarding the focus on implants. And today I'm going to focus on bone grafting and looking at just a little bit of bone biology and the effects around implant placement. I first wanted to introduce to you our summer externship program or clerkship program, which some of you may have applied for last summer, and COVID kind of threw a wrench in it. It is still open again, but it'll be somewhat modified. Some ORs might not be available, but if you're still interested, just let me know, let Masha know at the student service offices again, and we'll see if we can schedule. If you don't know what it is, it's a 2-week program. It's fairly intensive. You'll be following junior residents to all our hospital locations, a little bit of traveling, and you'll learn how to sleep in the funniest of places if you're interested in oral surgery. Today's lecture is looking at the implant site optimization, mostly focusing on bone grafting. The QR code is your link to the handout, and the references are primarily the handout, but other readings that you can do on the side are presented there. Again, here's the QR code for the updated handout for you. This is a lecture trying to attack many different little topics for you, just to give you an idea of what's available and some of the limitations that we have. So I'm going to go over some definitions, some of the wording, the nomenclature that you need to be aware of, the principles of the bone grafting that are required in order for us to get some success. A big issue is timing. When do we put an implant in? When do we put the bone in? When do you put the implant after the bone graft, after you take a tooth out? There's multiple little nuances that I want you to be aware of, because it's not just a matter of take a tooth out, put implant in right away. You can do that, and I'll give you the indications of when and when not to. I'll also talk about different gradations of grafting, from simple little socket preservation all the way up to full jaw reconstructions that we do in the operating room, where we take a piece of leg and put implants and put it into a mandible. That's also a type of bone grafting. So we'll go from one extreme to the other. A very common term, something you'll hear a lot, is GBR, or guided bone regeneration, where we're using membranes and bone in order to shield the tissue and reshape it in the hope that new bone grows underneath. It has really changed the way implantology has been practiced in the past 20 years. I'm going to step into how bone is harvested, all the different locations. I'm going to tell you the difference between mandibular augmentation and maxillary augmentation. I'll go into a little bit of detail on sinus lift. Talk to you, just briefly mention about distraction osteogenesis. And then finally, this is where I'll focus in on all the timings of when things need to be done. And final conclusions and observations in order for me to share with you some of the problems and successes that we can have with implants. Implants work very well, and when they do work well, it's great. But when they don't work, or they fail or get infected, it's a disaster, and it can be a bit of a nightmare for patients and as well practitioners. Nothing more anxiety-inducing than losing an implant. So the success of the implant in the bone depends obviously on a number of things: the volume of the bone, the height, the width, the length, the depth, the quality of that bone, the quality of the person's health on that bone, smokers, diabetics, osteoporotics, that all has an influence. Also the gingival, the adjacent tissue, not only on the site itself, but the adjacent teeth. The thought that someone with severe periodontal disease, with teeth flapping in the wind, and you take their teeth out and then it'll heal and then put an implant in and the periodontal disease is gone is absurd. The tissue, the entire tissue of the mouth has to be examined. The patient has to be consulted properly. You also have to look, at least from a surgeon's standpoint, I have to listen to the prosthodontist who's restoring this as to what they can and cannot do. Sometimes it's easy for us, if I have a nice big piece of bone, transplant it, place the implant, I sew it all up and I'm done. Then The heartache comes to the prosthodontist and the patient and getting stuck with an implant. I'll show you some pictures there. One of the hardest areas to treat are long-standing edentulous sites. They tend to have poor bone quality because they tend to be in older patients. The quantity is very small. You can see in this case here, this patient's had 20, 30 years of edentulousness and dentures, and that mandible's incredibly thin. You can't place an implant in there. And also these patients tend to be older and diabetic, and their bone isn't the best condition. They also cannot tolerate some of the procedures we can throw at them. Very early on, early 80s, when we started with the implants, you had a piece of bone, and you placed the implant in there, and then you cross your fingers that the prosthodontist would be able to complete the case properly. In the beginning, it was just oral maxillofacial surgeons placing implants in, and it was done in full sterile conditions, and the procedures were strict protocols. But now, over the past 40 years, implant therapy, the implants themselves have become easier, quicker, faster, better. That placing the single implant is now no longer the challenge. The challenge is getting that implant in the proper position. So in the past, you were stuck. You put the implant where the bone was. And, images like that are completely unacceptable. These are implants floating around just trying to, or at least they were initially placed in the bone, but they got loose and they fell in the sinus. And here's another example where very thin implants placed because there's no bone. This was restored with this plastic gingival cap, which acted nothing but a food trap. And sure enough, this patient sneezed this implant out. But now we know that you put things like this in. You should augment it and get bone in that area, and then you get a better sized implant. Even here, this is deceiving. You think there's a height of bone, but really there's just a small amount there. Here, this is just holding on by a thread. Okay, well, maybe 3 threads. And then the implant sticking out here to clip onto a denture. I mean, this is completely unacceptable. This is an implant going into the ethmoid air cells. Maybe there's some bone there, or probably obviously fell in there. You'll get problems with knockoffs in implants. A good implant fixture that you see, and when you're running around their faculty, the names of the implant systems, these are the best ones around. They cost, though, about $500 a fixture, so they're quite expensive. And this gives the opportunity to knockoffs that they come around your door in practice, and they're selling implants for $50. But you get what you pay for, so you have to be careful. So what's acceptable now, and I'm showing you this picture, this is done with grafting and an implant and good prosthetics, right? And it's the prosthodontist that dictates to us, listen, this is the best aesthetic position of that tooth. Make it so, make the implant so. And we can get these results, but it takes a lot of planning and good soft tissue and hard tissue healing. And if you were curious, that was tooth number 21. That's the implant crown. And truly, this only works with good teamwork. The aesthetic implant anteriorly is the most challenging to place because it's not just the implant. You have the soft tissue and the position that's really critical. So that takes multiple teams. I'm going to review material and words that we use about the type of bone. Autogenous bone, that's bone from yourself. Allograft, that's from another human. Xenograft, that's from another animal. Alloplast, basically I call it lab-made bone. These are the different products that you can use. Either you grab it from the person himself, or it's from a bottle. It comes in a lot of these come in different shapes and sizes. But what you need to remember, the only one that is osteoconductive, meaning bone will grow on top of it, it won't reject it. Titanium's osteoconductive. And osteoinductive. It allows for the promotion of the deposition of cells and osteoblasts and helps in reformation of bone de novo. And osteogenic, meaning it makes bone, is autogenous bone. So we take live cells from the hip, for example, and transplant it to an area that is live bone being placed, making live bone. The other materials are not osteogenic. some allografts, and these are allografts that contain bone morphogenetic protein, they have some osteoinductivity, but the remainders are basically osteoinductive. They're a scaffold. They tell bone, come and grow over here. So autogenous bone grafts are bone, if you're a patient, transferred from somewhere in your body, be it, and I'll show you all the different places we get it from. Here's a case, an extreme case, where my microvascular colleague harvested parts of the fibula, and then I take that piece of bone, put implants in it, and then reset it into the mandible, and then my microvascular colleague reanastomoses the blood vessels. This is the extreme. This is live bone with live blood vessels. Allografts, so they come from dissimilar members of the same species. So this type of bone has many different formats. It could be fresh frozen. It can be processed. It can be demineralized. Dentin is one type. Some BMP, both growth factors. So these are allografts. These are the most commonly used products. We don't always use autogenous bone grafts because you have a donor site morbidity. And oftentimes in smaller areas and segments, allografts work very well. Xenografts are taken from another species, a cow, pig, horse. Alloplasts are inorganic, and as I said, they're basically lab. They come from a lab. But some of them also come from coral, for example. There's hydroxyapatite, bioactive glass, phosphates, and calcium hydroxide. They just basically, as I said, act as a scaffold to bring tissue on board. On top of that, there are membranes that we have to worry about. There's different types of membranes in which we cover the bone. I won't go into these too much. Some of them are resorbable, some of them are non-resorbable, some of them are breathable, like a Gore-Tex membrane. And their goal is to separate the bony growth from either epithelial or other connective tissue invasions that can affect the growth. So it just acts as a bit of a barrier and cushion. The timing of implant placement is either done at immediate implant, so at the time of tooth extraction. It can be done as a delayed immediate, so we take the tooth out, let's let the area heal 2 to 3 months, then place the implant. That's the most common method. And then there's simply delayed. Delayed is the patient that shows up with a missing tooth. They've had it missing for years and years and years. So that tissue bed has matured. The issue is the delayed immediate is where we benefit the most of the bone growth and also the bone volume. And that kind of peaks after the extraction of a tooth. So that's 2, 3, 4 months, maybe 5 months, you can push it. But once you start getting into 6 months or 1 year, then it becomes a delayed because that bone matures, it starts to shrink away. Then there's the timing of the bone graft. We can do an immediate bone graft at the time of tooth extraction, and that's a socket preservation. We can do an immediate ridge reconstruction at the time of implant placement. So if there's insufficient bone, but you can get an implant with good primary stability, and that's basically the analogy is putting a screw into drywall. You can put it into drywall, but then it starts to loosen. You take it out, you put an anchor in, and then you put the screw in. This is the same thing with the ridge reconstruction done immediately. We do something to the ridge that acts as an anchor to help with that primary stability. But the most common one, especially in delayed sites, is to reconstruct the alveolar ridge, and that you need time. This is bone healing, can take 4, 6, 8 months depending on the site. I'll review that. The implant timing after bone grafting the terminology is bone consolidation or bone integration, maturation, remodeling. And this peaks, as I was mentioning, 4 or 5 months after the grafting. The resorption of the bone then starts at that point, and if you've grafted bone, augmented on the area, and it matures to that volume, it shrinks a little bit, and then after 5, 6 months, if it's not being used, according to Wolff's law, they have there just above me, that slowly starts to shrink away. If you don't use the bone, you'll lose it. So, timing. we'll start with socket preservation. This is only performed when the tooth is taken out and that is going to receive an implant, and sometimes it's done for pontic contours. If there is no plan for an implant, if it's an upper second molar or a third molar, socket preservation honestly is a waste of money and time and risk for patients. And it drives me crazy. So if an implant's not going there, socket preservation is not right. What we found, because it's small material, you don't have to use autogenous bone. It's usually a mixture of alloplastic material and sometimes a mixture of xeno and alloplast. Sometimes some people just use xenograft bone. But the whole point is that it maintains the volume. That's what you need it for. You have to make sure there's no periodontal disease, obviously. So if you have an adjacent tooth that's just loaded with plaque and it's dirty and there's mobility, site preservation on that site is you're just leading yourself up to failure. After you do site preservation, you still have to wait for the bone to heal, so 10 to 16 weeks on average. Sometimes we purposefully do a site preservation because as this area heals, new connective tissue and epithelium will grow over it. So here's a quick video of taking a tooth out. After you take the tooth out, the socket's left. If you do nothing, over time, that tissue, that bone will resorb. The soft tissue collapses and you get a defect grossly exaggerated here by the implant companies, or no, the bone companies. And you can't have the implants too short, too long, neither are effective. So in order to maintain that bone height, you have to preserve the area. Conventionally, with a fixed bridge underneath the pontic, you will lose some of that height. It becomes anesthetic and also is a food trap. So site preservation includes, at the time of extraction, the method to maintain the width and the height, and material is placed after the tooth is extracted. It's packed in very tightly, nice and dense, and then it's covered over with a resorbable membrane just like that, just to keep all the food, saliva, and crap out of there. Otherwise it just gets into the wound and gets it infected. And with that, then the bone is preserved and you're able to place the implant in the crown without any difficulty there. See how easy that was? And as I was mentioning, you're going to be inundated by manufacturers that come to your door with all this wonderful magic powder that resorbs. This stuff isn't cheap. They make a lot of money off it. And they make a lot of money off general practitioners that really don't study it, and they follow kind of the trends, but you just have to be really careful. You don't have to socket preserve everything. If you have a great site and all the walls are completely healthy, on a young patient, socket preservation is not needed. So next stage is option to graft is when we place the implant. So you've decided that you have a site where you want to place the implant, but there's just insufficient amount of bone. And this requires implant stability. So when you place the implant and it's greater than 35 Newton centimeters, regardless of the amount of bone volume, even if you catch just the very apical end, if you have good primary stability and no movement, you can then add bone to that area and it will form a connective tissue and some bond around that. This is really extra bone. I call it grout. It's usually just used to fill in little spaces. Then we place membrane on top of it, and you have to wait a little bit longer for these implants. You don't want to temporize them loading immediately. So I wrote there, don't be in a rush, because it's already a compromised system. You don't have ideal bone, but you have enough stability that you're happy to add some bone to the area. So that's immediate bone grafting at the time of implant placement. And then the most common one, at least that we do, is alveolar ridge reconstruction. And this is because we have larger defects, and this is where we require bigger bone grafts, and this is where we use autogenous grafting. It's complicated therapy. We see it with severe ridges, and oftentimes now oral maxillofacial surgeons are gone are the days where I would be placing, primary implants. I don't do implants because of my facial deformity practice, but any implants that we do are basically salvage implants from failures. So they require even harder treatment and grafting of bone properly. So the ridge reconstruction involves reconstructing the ridge in all 3 dimensions with larger grafts and waiting 5 to 7 months. I like this slide. So no matter how good intentions you are, or I really, really like doing this, don't confuse good intention with competency. Competency comes with time, education, treatment, mentoring, knowledge, following, looking, doing, and practicing. Just because you might like a certain aspect within a practice, in a general dental practice, even some in my surgical specialty, there's plenty of subspecialties that I might like to do, but I don't equate my competency just because I like doing it. You have to really develop your skills, and implants is one of those things that is a bit of a challenge. So GBR, guided bone regeneration. After we have a defect, we fill it with all our different types of bone and membranes and cover, we will get 30% decrease. We know that right away, so therefore we augment it by 3%. The quote we give patients is infection rates are about 3 to 5%, which means 3% of cases we might need to add bone again. You have to let patients know, and that's very upsetting for them. The volume of bone is related to the source, the different sources that we see. A cortical graft, very hard bone, we can get it calvaria, iliac, fibula, doesn't resorb very much, but it does get infected more because there's not as much of a blood supply. Cancellous grafts are mostly cellular, so inner iliac crest, all the cancellous bone from the tibia to the rib, they take a little bit more. The issue also is epithelialization. You have to block out epithelial cells from getting in the area, and that's what's meant by guided. So here's an area. You can actually see the defect here on the x-ray. So fenestration. The bone coronally is not too bad. So you place the implant, good primary stability. Right? So at the time of implant placement, this is where we're adding some grafting. So this is the defect here. We take a combination of bone from the tuberosity, happen to be taking out the wisdom tooth, take out the wisdom tooth, take a little bit of bone, mix it up with some allograft, mix it up with some bone from the trephine, from the implant drill, your osteotomy. You mix these all together, you pack it over top, put on a membrane, cover it all over. Here's the implant with a membrane, suture it all up, and about 4 months later, this is the tissue, looks very nice with the membrane. You open it up. I didn't want to open it too much, but you can see it's all new bone overlying it. So without a cosmetic defect and a nice solid implant to make a crown. So GBR basically requires a barrier. And this is to stop non-osseous ingrowth from some connective tissues, granulation tissue, and epithelial tissue. These membranes can be we can use periosteum. Most often it's collagen. There's an increased use in the use of dura. We use Gore-Tex membranes that need to be removed. A lot of time mesh membranes, titanium mesh membranes. And some membranes have Gore-Tex and titanium in them. You still have to remove them. Also, these membranes act as a barrier for the bone, but they help the overlying gingiva by improving the biotype sometimes. So these membranes will let cellular fluid, oxygen, carbon dioxide release. There is a porous membrane to it, but it stops any cellular exchange. We like using titanium because it has a good shape to it. It's very strong and biocompatible, but it's not easy to use and can be very expensive. You can get 3D printed titanium meshes that will hold the bone in place. You still need to put a barrier over top of this because this will help form and shape the bone, but you still need some cellular blockage. GBR is very, very technique sensitive. Dehiscences occur, where the opening opens up. The bone and gingiva can get infected. There's resorption of the bone that's unpredictable. Sometimes unequal consolidation. So you have a little area, this whole area is solid as a block, and for some reason the very top doesn't heal. And that's a little frustrating. That's where you have to graft, sometimes at the next stage of the implant. If there's any mobility, there's failure there, so it has to be fixated properly. Then the membranes, but now we're using more and more resorbable membranes, and if you tuck them away properly after 4 or 5 weeks, they resorb. Some of the older Gore-Tex membranes, all it took was a little corner to stick out, and the whole thing would be lost. So, where do we get all this bone from? I'm going to just quickly review the most common places, and also places just for interest's sake. Our workhorse is the iliac crest, the anterior aspect of the iliac crest. Sometimes we take posterior for larger grafts or trephine. Costochondral is the rib. There's intraoral sources, tibia in the leg, calvarium. Sometimes we'll take a little bit of the pip. And other sources are harvested types of, I'll talk about platelet-rich plasma and things. So the iliac crest is really the gold standard. And this is used in multiple specialties. So dentistry, maxillofacial, orthopedic, plastic, neurosurgery. Anytime anyone needs a piece of bone, we go to the iliac crest. The reason being is it's very safe, it's easy-ish, the morbidity is very low. In our case, I have the residents harvest the bone while I'm preparing the face, depending on what I'm doing. And they get a piece of bone from me in half an hour, and then I can use that bone right away. So we can work in teams, so it's quicker. And in general, the 5 by 5 centimeter piece of bone is what you can get, sometimes a little bit less. It depends a lot on the size of the patient. Complications, like any surgery, infection, hematoma, paresthesia, they can get a little scar, it can be sore, and there's some gait disturbance initially because we take off the tensor fascia lata that connects the hip to the knee, and going up a stair or as you sit down, that's sore for a couple of weeks. I wrote surprise fracture. Sometimes I call it the lunch bag letdown because you're anticipating a certain volume of bone. So for small volumes, anterior iliac crest is good, but if you're expecting a large volume, you might want to take an x-ray because you can get there and get very disappointed with the amount, and then you have to go to the other side, and then you should have gone to the posterior. So the anterior iliac crest, so this is the patient's feet are over here, the head's over here. We make an incision. First we outline, we don't go right on the crest, we just go below it and then pull the skin over top. This way it doesn't, if they're wearing a belt, it won't get sore. So we open this up, we use cautery with large fork retractors, and here's the crest of bone. This is pretty big, isn't that a good chunk of bone? We go to the medial aspect of the hip, and with a saw we cut out our little piece of bone, either 1 by 1, 2 by 2, 3 by 3, 5 by 5. I'll steer the residents as to the size that we need, and then this chops off. We reflect the iliacus muscle, so it's on the inner aspect, not the outer. We take out the piece of bone, and there's still a little shell of bone that's left there. We'll remove all the marrow that we can. We'll put in hemostatic agents inside here, close the muscle up, close the skin, and we're all done. So we can get nice big pieces of bone. This is wonderful bone. Sometimes if we're taking out a very large one or posterior iliac crest, I'll put a small catheter inside the wound, and the residents, the nurses, will inject Marcaine 2-3 times a day just to keep the area numb so the patient's not sore. If we need more bone, then we go to the posterior iliac crest. So sometimes a bilateral sinus or a big continuity defect. We get much more both cortical and cancellous bone. There is less morbidity. It is because what happens is after you take the bone off and you reflect the gluteus and take the bone, close up gluteus, and the patient sits down or lies down, it acts as a compressive force, so there's less chance of hematoma. So there's lower morbidity, and you get a big block, 8 by 8 of bone. However, it takes longer. You can't two-team it. The patient has to be prone. You take the bone, then you have to flip them over when they're asleep, and it's a whole show. So this is iliac crest. The patient's put with a little bend with the bum sticking up in the air. We palpate the vertebral column and the posterior ridge, and we cut directly onto the ridge. There's also fewer nerves, at least in this area. If you go lower, you got to be careful. Fewer nerves and just the single iliacus muscle gluteus medius that you have to remove. You take out, and as you can see here, you have lots of bone, lots of very good bone from posterior. Another method is to take trephines. So these are little punctures. This is it in place. I've got my finger on the inside, outside, palpating the hip. Another resident holding the wing spear. And then with my trigger finger, I just go along and we get these little cores of bone. This is for good. We use this for cleft palate cases where I just need small little plugs to fill into the gap. And nice healthy bone. Here's a video of it going down. I slowly pump it down. And once it reaches the bottom, it engages, the very tip closes, and then I pop it off, and there it is. And there's a little piece of bone. So minimally invasive. This is, patients hardly feel this. It actually works quite well. And there's the bone coming out there. It looks scarier than it is, but it works nicely. So in summary, iliac crest is the gold standard. Anytime people have discussions or talk about implant bone grafting, they say, oh, this product is very good. It's almost as good as iliac crest. It's still, regardless of everything that's out there, iliac crest is our go-to. Particularly for us where we're doing salvage procedures or it's a second time failure, we have to go to the iliac crest. We tell the patient outright. Morbidity in our hands is very low because we do a lot of these. So gold standard is autogenous bone, and gold standard is iliac crest. Because we can also get not only the hard cortical, but you get a lot of cancellous bone. Next type of graft that we take is costochondral. And we use this very sparingly nowadays. It's used primarily to reconstruct the ramus condyle portion. It's again autogenous. We have cartilage on the top to act as an articulating surface. You can get good bony union. It does grow the cartilage, so we'll use it for children when we're reconstructing their temporomandibular joint because it will grow as they grow, but it's not that predictable. Sometimes it grows too much. So it is mostly applied to TM joint reconstruction, but sometimes people would have tried, this is a photograph from the AO, if you see this, this is the Association for Osteosynthesis. It's not my case, but this is very thin. This bone isn't very good. It doesn't hold well, it's not strong. So we take it from the inframammary crease, just below the breast, and we hide the incision in the scar there. These are very easy to harvest. The only complication is sometimes you get pneumothorax if it's done too aggressively. But here's a case, we're still using it. Here's a case that I did last year. It was an ameloblastoma on a 45-year-old woman. The tumor was resected along with the ramus, and the condyle had to be resected because we couldn't fixate it. I went under her breast and I got a nice piece of rib. I went to her hip and got another block of bone. I mixed the hip and the rib to replace this mandible here. I thought I had a post-op x-ray. I have a nice x-ray afterwards. Anyways, it looked great. Other sources of autogenous bone will be intraoral. And now these are most commonly done by our general dental colleagues, and as well our periodontal colleagues will use intraoral sources for small grafts, and they work very well, but you have to be careful. Either from the symphyseal region, but the problem with the symphysis is it's very hard. It's not an easy procedure, but in our hands as dentists we can do good delicate procedures, so you just have to be careful. But the mandible can fracture. If you poke through the lingual, you can get bleeding issues, so you have to be very careful. It's not just when we'll just carve out a piece of bone and off you go. I don't like using it because patients always have this wooden sensation to their teeth, and it's sore for quite some time. They do sever the incisive branch, so just below the gingiva, the sensation is lost. The next is a ramus bone. Ramus has a greater volume, a little bit harder as well. and there's some cancellous underneath, but the cancellous underneath is just in and around the inferior alveolar nerve, so you have to be careful because there's a high risk of nerve damage, especially if part of that bone is stuck onto the nerve. We take it from the tuberosity. I don't like taking this. We try. It's very fatty in patients who, as they get older, and it's a little bit of bone and not easy to work with, and you can carve into the sinus if you're not careful. But some tuberosities are big, and you might as well benefit from it. So here's the symphysis, all intraoral. We do a vestibular incision. Actually, the incision is taken out onto the lip. You don't want to go deep in the vestibule, otherwise it starts to tug away. I really only reserve this for grafting in the same area. So here's a lower incisor. Here's a little bone. We carve out a little piece of a recipient bed. We carve out this with a 701. We we shape it, put it in, hold it with a screw, and then 5 months later put in the implant and then the crown. And you can see here the x-ray, the tomogram, just showing the volume increase of bone. So this is about the only time I would use symphysial bone, is if I have to graft just this lower incisor area here. And this is very, very hard, and you have to be careful. And it has happened to me where I make a hole with the screw, and I tighten, and the bone cracks. Then you have to think of other strategies to hold it in place. So ramus bone, we can take, here's from the ramus, we can take that out, and we put it onto the same area, or you can graft it in the maxilla or in other regions like that. Some people have very big external oblique ridge, and this you can tell by palpating, or something. You take a pen or even a CBCT to see if you have enough volume. Some patients, and you'll be deceived, for example, prognathic patients have very, very thin external oblique ridge, so you might want to double check with an x-ray before you chase that bone. But this works very well, and as I said, the issue is the nerve underneath. This was a patient I did with the anterior maxilla, where I took the ramus, I held it in place, I put my grout, my allogeneic powder in the area, cover it over with a membrane, and suture it up. 5 months later, nice tissue, good bone. I removed the 2 little screws that are holding it. They're very small, 1.5 millimeters, and I'm putting in these implants. These are 4.1 millimeter, I think. Nice little position and nice little restoration. But this can only be done, this wide defect, with autogenous bone. Pushing this just with alloplastic bone, it can work, but a higher failure rate and then a more frustrated patient. So tuberosity, as I said, sometimes is pretty good. If you get we can use a chisel to chop it off, and we get a nice cortical bone. This is if you need a little bit, but as I said, sometimes it gets a little bit fatty. The proximal tibial head is something that we have been going in and out of fashion to take. So this is the knee, okay, the fibula, tibia, and this is tensor fascia lata insertion just over, and this is where we make the incision, a little hockey stick here. We label certain insertions of muscles that we want to stay away from. You get a good volume of bone. It's pretty easy to do. It takes just minutes because there's no dissection. It's just cutting right over what's called Gerdy's tubercle. But you do have to avoid TFL, otherwise. That I found, I stopped using it because, most of the implant patients we do are older, and the older you get, the fattier the marrow is. But here's a quick little incision, little postage stamp, poking around, a little incision like that. And then I use a number 9 periosteal elevator, and just like an ice cream scooper, and just scoop out all the bone. You get a lot of bone. Calvarium we take when we have facial trauma and we've lost certain segments of bone and we're doing a flap in the head anyhow. We'll take calvarial bone. It surprisingly is safe and easy. Calvarial bone is 2 things. Calvarial bone is an Oreo cookie. So we just take out the outer piece of the Oreo cookie and use that. It's very hard, very dense, and it stays forever. It's great material. But for implant placement, I wouldn't really suggest it. This is a picture borrowed from someone, I forget who. But here's the implant. So this does, the audience looking at that, no, it won't work. So some grafts really have very little value. And that's where I'm presenting all the different types so you can get a feel for what works well, what doesn't work well in certain conditions. So this will just get completely infected, and I think it did fail. And then here you go, making a scar in the patient's head. I don't know the story behind this, but anyways, calvarium is not really useful. Then you get the opposite. Then you have the promotion of things like platelet-rich plasma. Over the past 20 years, it's been up and down. It's coming back as a PDRF formulation. Anyways, PRP, I don't know if you've had other lectures on it, is a combination of factors from platelets, from plasma, and it contains all these wonderful transforming factors and growth factors. It has all of these, all implemented in a small little volume. What we do is we get this little vial of plasma, we spin it down. There's a platelet poor section, a platelet rich section, and the centrifuge, after certain minutes, you can pipette out what you need. So in the late 90s, early 2000s, we were using this a lot because we had centrifuge machine, and we'd set up platelet poor plasma, platelet rich plasma, put in the bone graft, then we'd put this over top of the bone graft. It would set, so the handling characteristics are great, and the theory behind it was that it would promote bone growth. It does allow for better healing, a little less swelling, early on good soft tissue issue. So platelet-rich comes from patients' own blood, and right now they have them in dental offices where you need to learn how to do a phlebotomy, take out a small piece of bone. They have a machine that's yay big, and you can spin the bone down, pluck out the PRP, and put it on your bone graft. So it's easy to do. Usually mix it with other components. It's nice, it's moldable, and that's why the celling feature of it is quite good, because you can pack the bone. It does have good attributes. Initially, it does seem like there's a little less bleeding and swelling, but long term, and no one can try to convince you, after a year, PRP, non-PRP, the bone is the same. So use it for its handling characteristics, but for someone to say, oh, this grafted site requires PRP because it'll be better, it's long term, it's not. So there's a big push, and I have one of my colleagues is a huge promoter of PRP, and the two of us get to fights all the time. Luckily, I'm bigger. But the PRP tends to also have a huge thing behind it, a press behind it. Tiger Woods, poor guy with the legs just now, but his back, it made him better in his swing. It grows hair, it grows bone, makes your skin look better, arthritis. It has all sorts. The O shot, that you'll have to look up yourselves. You're too young for that. That's the orgasm shot. They use it for all sorts of crazy stuff. Lance Armstrong loved it, as you can tell. And it's promoted now for financial reasons, which is really inappropriate. In the end, I call it profit-rich placebo. It's a bit of a snake oil. But we still use it. It handles well. Hematoma formation, maybe. Less edema, maybe. It's not really proven, but it does not improve long term. So I just want to keep your eye open about PRP. And what's happened is it swings, the pendulum swings. So right now you can get these little PRP boxes. This is from Alibaba. I think there's one here for $35. They initially were selling these about 10 years ago for $10,000. You could buy the set plus all the ampules. They give you, I think, 30 free ampules, but now you can get it for $50. I love Alibaba. Okay, now we'll go into heavier reconstructions, let's say, of the mandible. Mandible is very difficult to treat because the bone itself is very hard, so it doesn't tend to accept grafts well, and the transfer of nutrients is a little bit harder. And also, the size of the graft, the height of the graft, there's a lot of little limitations that we have. And it's the base of the bone that really dictates it. We have to know the course of the inferior alveolar nerve. It's critical, obviously. We have to get a bigger piece of bone, because as I said, there's always shrinkage just with GBR, but when we involve the mandible, again, there's probably about 30% shrinkage. One of the options we do is tunnel, so a long edentulous span. Rather than cutting it all open, we make a little tunnel and shove our little piece of bone or or a cylinder of bone in that tunnel. That helps with the decrease of dehiscences particularly. For large mandibular augmentation, it's iliac crest, anterior, posterior. It really is the only one to do with this. We often use titanium meshes to help maintain the height of bone. To augment it vertically is very hard. Laterally is very easy. Laterally and a little vertical works well, but when you want to go very vertical, it can be a challenge. So here's a titanium mesh. This is iliac crest bone mixed with some alloplastic bone. It's all morselized. You mush it up really well. You put it over the defect, and then you take your time and we pin this titanium mesh to the bone, cover it with a membrane, and then after 6 months, you get a nice little piece of bone. This, I have to admit, is exceptional. It doesn't happen all the time. I just wanted to bring up something called nerve transposition or nerve lateralization. We have to do this with a general anesthetic, and what we do is we move the inferior alveolar nerve. I cut it out. I use a small saw to cut the bone. I flick out the bone. I find the nerve, and I keep the nerve out of the way. So this is a nerve band. I place the implants. I put some of my sprinkled allogeneic dust. I call it foo-foo dust. I put some of the foo-foo dust over here, put the nerve back in place, and these implants are now very long, but they integrate really well. Patients will all be numb for about 2 months. Long-term, 15%. They have a little bit of hypoesthesia, not really dysesthesia or anesthesia, just more hypoesthetic. But for a lot of patients, they would much prefer that than nothing, especially if the bone ridge is small. So this is an idea of the implant. So you can see here where this piece of bone was removed, and then it's reinserted. But between the implant and the nerve, we put some foo-foo dust. Another technique is called a tent pole. This works really well. However, it leaves a big scar in the anterior face. You have to go extraorally. You can use long implants. You get 4 or 6 implants. Again, we have to use anterior iliac crest bone. You have to make sure there's no perforation intraorally, because if saliva contaminates this, you're lost. And we use periosteum as the membrane because, again, we're not entering into the mouth. So here's someone with severe resorption. Look at that. There's no bone here whatsoever. There's hardly any ridge. Patient goes to sleep. This is from underneath the chin. The incision is done just along the inferior border like that. This is flapped open, periosteum. Then we put the implants in. These are markers, indicators. So we get nice 4 implants through that small ridge. And then we take iliac crest bone and we pack the entire area. We rebuild this. As I said, we don't need to put membranes because we haven't poked through the mouth. So the periosteum is our membrane. We put this over top. 5 months later, we uncover the implants, because remember, the implants are already there. We uncover the implants, and then abutments are placed and a denture is made, and this really restores patience. Maxilla is a little bit different. Any lateral augmentation is very successful. Vertical augmentation, so multiple materials and approaches. We have key primary closure, because unlike, let's say, the tent pole I just showed you, we don't get saliva contamination. But for maxilla, you always go intraorally. You're always going through mucosa and gingiva. So contamination is a problem. Vertical augmentation. So going from the ridge up is easy, and that's a sinus lift. Going from the ridge down inferiorly is very hard. The tissues aren't flexible. Sometimes we have to do vestibuloplasties. You compromise the tissue as you push it down. So vertical augmentation of the maxilla in an inferior to the ridge is hard. So here, for example, is I think this was a kid with a bike accident, lost all the front teeth. We take, here's my measure. So as the residents are down to the hip, I call down, I need a 3x3 block of bone. We poke little holes in the bone so that there's transfer of nutrients. This is part of the iliac crest. I cut it in half. I also shape it to the area. I pin it down with 2 screws. I put foo-foo dust all the way around. I put my grout just to fill this area, cover it with a few membranes, and suture over. Here's another small defect, same sort of thing. This is iliac crest on a small defect because this was a failed site. So I'll get referrals from other specialists where they've had their implants fail and they know the best is to use iliac crest. So you might think, oh my God, that's so extreme. If this was an edentulous primary site, I would not use iliac crest, but since this is a failed site, I use iliac crest. We get a nice little blob of bone. In this case, I already showed you. And the bone all heals up well. So edentulous maxilla, here's an example of a bilateral sinus lift, okay, with ridge augmentation. And the sinus lift is done quite commonly. It's because of sinuses that are pneumatized, which really means the teeth are gone, so the bone shrinks away, and it shrinks away from the pressure of the sinus air and also from the loss of pressure from the mouth. It's not that the air is causing it to expand. We find technically about 50% of first molar sites will need some sinus augmentation, because usually these teeth have been beaten up a little bit, and periodontal defect as well. It's not an easy procedure because some patients have very thin sinus membrane or Schneiderian membrane, and if it gets perforated, then there's obvious contamination and there's a problem. Then you get contamination from the mouth, so sinus lift can get insulted from two sites. But basically a sinus lift is a little window is made in the bone. Here's the residual bone. The membrane, it's not like this, it's much thicker, it's lifted up. So here's a regular sinus, this is now expanded, it really shrinks in both areas. The bone is filled up into the area. This is usually a combination of maybe autogenous, alloplast, xenograft, all goes in here. And after 5 months, 6 months, it consolidates into regular bone, and then the implant can be placed. This is an area where you can't, when the bone is this thin, you don't have primary stability. You can't do both at the same time. This is an image of the anterior maxilla, where iliac crest was placed over it. Sinus was also lifted up, and here's the thin membrane. And bone was placed inside, and sprinkled on top is something called tisseal, or this is where people might use PRP to help with the consolidation. I'll use something called tisseal, which is fibrinogen, and we get this in the operating room, and there's no morbidity to the patient. So the sinus lift does need, I wait 4, 5, 6 months. I might take a CBCT just to see how well the bone is consolidating or healing. In general, pretty low complication rates, but the issue is the failure rate. So not so much complications in that big infections or problems and nerve damage. It's more the fact that the bone may not consolidate. And 5 to 10% is high. It's a low overall failure rate, but for this type of treatment and the cost, it's a very frustrating narrow rate down. If it fails, it's a problem. Patients are not happy. If you get any perforations of the Schneiderian membrane, you have to put another membrane in the sinus and a membrane on top of the bone. Sometimes you get into the sinus and it's all infected, it's all pus, and you have to abandon the procedure. That's why you always want to go into the sinus first before you go harvesting bone if you're doing autogenous bone. There are many little options and types. I think the most common would be an allograft from another human, DBM, plus the xenograft like BioOs, just to mix the two. So here again is the sequence of placing the bone, letting the area heal. 5 months later, nice solid blocks of bone with the implants and the restoration. Here's an image of just a small sinus lift. Bone is placed. So here's a CBCT done 5 months later. Here's the pan, and that looks great. I mean, that's a good. Here's where it didn't consolidate. So this is some of the areas that are a gap, but that's not going to be a problem. We'll get around that. But this is where we have problems. And this is the width, and here's the implants that go into place. So that first pan I showed you, so we put implants in the front on veneer grafts, sinus lifts, and all these went in. We're now, this is probably a 20-year-old slide, but we've discovered that one of the things we can do is place longer and fewer implants, expanding our ridges, and another surgeon will talk to you about that, implants all in a day. But these work well. Just for historical sake, I was going to touch on alveolar ridge distraction. So distraction osteogenesis, I will be talking to you about that in detail next year, but it's basically a cut in the bone and a purposeful separation of that callus, and that lets the bone lengthen. So it's a limb lengthening procedure. So an appliance is placed, one placed here, it's screwed in place. A saw cuts the bone and breaks the bone. And then the patient has this little key, and they turn it every day, a little bit, a quarter millimeter every day, and this over a 2-week period will increase in height. And in here will be a callus, and that callus will solidify to bone. And then you remove this appliance after 5 months and put in your 2 implants. I've never done it. It was a big fad about 10 years ago. I still think some people are doing it, and hopefully in their hands it works quite well. But failure rates are high. It also, patient compliance is a big thing. Cost, but what happens is sometimes you get a knife edge ridge, and you're pumping up a knife edge ridge. You really don't have that volume. So, but I thought it's interesting to share. So finally, I'm just going to look at the one last item about extractions, and I'm going to go on to various scenarios, and this will repeat some of the things just so you get an idea of when and how. So extraction teeth, grafting sites, and placing in implants and final prosthesis depends on a lot of things. The tooth itself that you took out, the bone quality, the size, location, angulation of the implant, aesthetics, for example, and also the final occlusion. All these are little elements that we're constantly worried about timing. There are 4 options in the implant world. Delayed implant placement with delayed loading. That's the most common one. I'll see a patient missing their 3/6 for the past 10 years. That's a delayed implant. The bone's not too bad. I flap, place the implant, I close over, and then the patient comes to the prosthodontist 3-4 months later as a delayed loading. That's the most common scenario. Probably 80% of implants do that. Then everything else will be explained. So as I mentioned, most cases, these are the edentulous spacing, inadequate bone volume, good bone quality, good perio, maybe not the most ideal. So we place the implant. We may need to add some soft tissue, hard tissue and soft tissue. Usually you don't want to temporize, or if you do temporize, you keep it out of occlusion. You wait 3 months, then place the final abutment. And you might need some secondary manipulation and place the crown. So you can see a lot of little steps, even for the most simplest one. Sometimes you can do a delayed implant placement with immediate loading. So this is an edentulous space with a very good bone height, very good bone quality, excellent perio, no occlusal stress whatsoever. So there you can place the implant, high torque, and then you can place the abutment and crown, at least a temporary one, slightly out of occlusion, and you can have, and this will be usually done for, this is the Canadian scenario, the hockey puck to the front teeth. Hockey puck smashes the teeth, take out the tooth, or can't be replaced, and about 2-3 months later the patient presents for implant placement. It's usually a young patient, and he or she will have a good volume of bone. We place the implant, and the torque is high enough, we send the patient right away to the restoring dentist, who will put in a temporary crown, so right away the patient has something there. These work really well. So that's a typical scenario, the Canadian implant. So sometimes you'll have the same scenario, you'll have a scenario where you're immediately placing an implant, but you're delaying the load. So this is a case where you have a fractured tooth. So you use the same hockey puck, but there's good bone, and the timing is right. You might have some exposed threads or a jumping gap, and some gingiva that you want to maintain, but there's good perio. So these cases here, for example, the hockey puck smacks the front tooth, you see the patient right away, and there's good bone. So you take the tooth out, place the implant. You may need to graft a little bit, but you don't want to load that right away. Or you can give it a bit of a fake load, but you don't want any pressure on that. 8 weeks later, solid implant, and 2 weeks after that you can place the crown. So here's a case of a fractured tooth. It's taken out. The indicator shows it's a good position. I place the implant in, and this is the jumping gap. You can see almost 360 degrees or 300 degrees around the implant is solid integration. There's just this little pocket. So in this little pocket, I keep the bone from my osteotomy and just pack it in there, and I'll put this little plug on it. So there's immediate extraction, immediate implant placement, but I want to wait. If this was a front tooth, maybe some form of temp, but as a premolar, you're going to go to your dentist in 8 weeks, and you're going to start fabricating the crown. So immediate implant insertion with delayed loading. Then there's immediate implant placement with immediate loading, and this is for the movie stars and the NHLers. So you have a fractured tooth, uninfected. This will be good for small roots, for example, or central incisors where you get good primary stability and without any damage to the alveolus. So hockey puck to the head, take the tooth right away, put the implant in right away, excellent torque, good perio condition, put on a temporary crown right away, but keep it out of occlusion. And then after 6 weeks, usually later, then the porcelain crown is placed. So immediate implant placement with immediate loading. So this was my patient, hockey puck to the head. The tooth saved the day. It's fractured right down. This is a non-salvageable tooth. It's extracted. We do all our fittings to make sure we get it in the right spot. The implant has to go a little bit deeper for good emergence of the crown. I have a little bit of a jumping gap, but I have excellent primary stability. The patient goes to the dentist the same day and puts on this temporary crown. This is a composite crown, I think. Resin crown, whatever you guys use. And this is put in the same day, completely out of occlusion, but for aesthetics it's fantastic. You can't do this all the time. So for this immediate loading, you need what I call the perfect storm. Good bone, small root, no pathologies, good patient too, very little jumping gap. It saves you time, fewer interventions, and the gingival results long term are actually very good. And that ends my discussion. So long-term problems with implants and grafted tissues. Over time, though, we have discovered that there is shrinkage of bone even long-term. As I was mentioning, implant success is proportional to getting that timing correct, looking at the proper bone health, proper attention to the gingival health. I don't want to ignore it, and I know you'll be getting lectures also in perio and with us about the gingival condition. It has to be a good technique. It's very delicate procedures. We are having challenges with vertical augmentation of bone in the maxilla and mandible. And in the aesthetic zone, immediate implants are quite the challenge. You don't want these to be the first implants you do. That last case I showed you with the broken tooth in half, that's not the case you want to start with. So any compromised implant placement or inadequate size, poor angulation, poor prosthetics just leads you up to failure. The theory of chaos, it's one little compromise at a time, because as you see, there's many steps along the road, and all it takes is for one or two of these to go wonky, and then it doesn't work out well. Bone grafting is essential for the survivability and for the success of our implants, especially in some of the aesthetic cases. So we can't be shy. You can't look at the fail, we're going to try to do this without a bone graft. Right away, you start to compromise the case. Implant, as I said, are costly. We see the disasters at the end and the frustrations that patients go through. So something you always remember, do appropriate work, and always do no harm in whatever you do. And here is, again, the QR code for the lecture. Thank you very much for your attention. And as I said, just contact me if you have any questions. And as well, don't forget about our externship program if you are interested. Thank you very much.